Hello everyone, my name is Sierra Turner and welcome to today's training session. Today we will be discussing Chapter 1 from the Community Network for Youth Development Guide. This is Session 1, Models of Youth Development. Many of you received this guide prior to today's training, and that is great. This online training will help you highlight and solidify key concepts that you can take with you as you continue your work with Project Hope. If you haven't read the guide prior to today's training, that is A-OK. Some of these concepts may seem slightly unfamiliar to you at this time, but just hang in there. Everything will make sense in the end. Okay, let's get started. There are different approaches to working with young people. But before we go any further, let's pause here. When we say young people, who do you think we are talking about? Young people, also referred to as youth or adolescents, are not a homogeneous population, meaning that young people hold distinct and unique characteristics that make them unalike from other older and younger populations. Young people experience a variety of unique circumstances and therefore have diverse needs. Okay, so now that we're on the same page, let's take things a step further. Now that we all know what a young person is, let's take a moment to think. Since we know young people hold distinct and unique characteristics that make them unalike from other younger and older populations, there must be certain approaches we could use or implement specifically when we're working with youth, right? If you are agreeing, then great, because that is true. There are certain approaches and strategies, I guess you could say, we use to implement specifically when working with young people. These different approaches and strategies to working with young people can be thought of as mental models or sets of assumptions about what young people need to develop, what young people think about adults, and what adults think about young people. Do they think they're irresponsible or just still figuring things out? Are they problems or resources? In today's training, we'll be discussing 3 main models that underlie programs for young people. These are called the prevention model, the deficit model, and the youth development model. All right, this slide displays our learning objectives for today. By the end of today's session, we will have 1, defined and discussed the prevention model, 2, defined and discussed the deficit approach, and 3, defined and discussed the youth development approach. And of course, we want to give a special thank you to HRSA, the Health Resources and Services Administration. Without them, this project and this training would not be available for us today. So again, a huge gratitude to HRSA for all of their support and contribution to this project. All right, here we have our first model, the prevention model. The prevention model is aimed at reducing risks or threats to health. In other words, prevention focuses on preventing bad things from happening. Because of that focus, it emphasizes threats and how to reduce them. Typically, there is a focused population in mind when the model is implemented. In our case, we are applying this model to our young people involved with Project Hope. You may have heard researchers and health experts talk about 3 categories of prevention: primary, secondary, and tertiary. I'd like to pause here. What do you think they mean by these terms? Well, I'll tell you. Primary prevention aims to prevent disease before it ever occurs. Therefore, primary prevention addresses all persons. Primary prevention prevents exposures to hazards that cause an illness and attempts to alter unhealthy and unsafe behaviors that can lead to that illness. Our work with Project Hope aims to eradicate opioid use disorder. Shorthand, we call it OUD. Primary prevention in this case means keeping people from using opioids for non-medical reasons. And knowing this, what do you think might be some examples of primary preventive measures of OUD or substance misuse in young people we could implement to help us achieve our project's vision? Long-winded question, right? Well, I'll tell you. Some examples of primary preventive measures include legislation and enforcement to ban or control the use of excess opioid prescriptions, and education about healthy and safe habits regarding opioid use. Next, we have our secondary prevention. Secondary prevention aims to reduce the impact of an illness that has already occurred. This is done by detecting and treating an illness as soon as possible to halt or slow its progress, encouraging personal strategies to prevent reoccurrences, and implementing programs to return people to their original health and function to prevent long-term problems. Therefore, secondary prevention addresses select persons at risk. In our case, examples of secondary preventive measures would include addressing public labels of being morally weak or addicts for those who are experiencing substance misuse. These labels can result in individuals having trouble obtaining care. We could also look at addressing healthcare professionals' stigmatization of beliefs and provision of suboptimal care. This reduces patients' engagement with drug treatment and is a great way to address secondary prevention. Next, we have tertiary prevention. This level addresses persons who have the outcome of interest, so in our case, opioid use disorder. Tertiary prevention aims to soften the impact of an ongoing illness that has lasting effects. This is done by helping people manage long-term, often complex health problems, such as opioid use disorder, in order to improve as much as possible their ability to function, their quality of life, and their life expectancy. Examples of tertiary preventive measures include access to treatment and harm reduction services. Physicians with DEA waivers to prescribe buprenorphine, most not prescribing at capacity. Also, provider distancing, patient stereotype, difficult, dangerous, or involved in criminal behaviors, or avoid legal scrutiny associated with the considered mill pill, and distribution of overdose education and naloxone. So these are all ways we can help address access to treatment and harm reduction service. And I know that was a bit of a mouthful, so I'll go over those again. So we could look at physicians with DEA waivers to prescribe buprenorphine, most not prescribing them at the capacity that they can. We can look at provider distancing, so we can make sure our patients aren't being stereotyped as difficult or dangerous. And we can also look at the distribution of overdose education and naloxone. All right, so with tertiary prevention, you are softening their impact by helping people live their OUD as best as possible. Now, the prevention model is important because for many health problems, including OUD, a combination of primary, secondary, and tertiary interventions are needed to achieve a meaningful degree of prevention and protection. Now we have our deficit-based approach. This approach is also referred to as DBA. The DBA focuses on perceived weaknesses of individuals or groups, such that individuals or groups, or in our case youth, become viewed as the problem. The deficit approach overlaps with the prevention model in that it is focused on reducing risky behaviors that lead to OUD. For young people, these might include things like behaviors that contribute to unintentional injuries and violence, sexual behaviors related to unintended pregnancy and sexually transmitted infections, including HIV infections, alcohol and other drug use, tobacco use, and unhealthy dietary behaviors. With the deficit approach, program success is defined as the reduction of these behaviors in the target population, and in our case, young people. However, with this approach, it is embedded in its assumption that something is wrong with young people, and that's what gets them into the program. After all, deficit does mean lacking. If you have a program geared entirely towards reducing deficits, it runs the risk of failing to see young people as whole and sees them as a set of risk behaviors that need to be fixed. As long-term evaluations of these deficit-focused programs become available, they begin to show that single-issue programs rarely achieve success in eliminating or even significantly reducing problem behaviors over time. In current practices, we no longer define program success in that way as simply as a reduction of these risky behaviors. So with that, we currently look at our youth development approach. Our last model in today's training is the youth development approach, also referred to as YDA. The youth development approach arose in response to some 20 years of deficit-based approach towards youth policy and programming in the United States. Unlike the deficit-based approach, this approach promotes healthy development for all persons, not just the problem youth. In turn, this approach both increases the positive and reduces the many undesirable outcomes, not just the target problem behaviors. As a pioneer in youth investment, Karen Pittman once said, "Youth are not problems to be solved, but assets to be developed." The youth development approach fits nicely with the prevention model. Now, can you think of approaches to the primary prevention of OUD that is preventing any non-medical use of opioids that focuses on developing young people? One example might be helping young people find something that they are passionate about and is more interesting than experimenting with opioids. Or helping young people identify and name their emotions and talk them through in healthy ways so that opioids aren't attractive in any way, and we try to avoid negative thoughts and feelings surrounding them. Now, the secondary level of prevention is reducing the impact of a condition after it has already occurred. From the youth development perspective, secondary prevention of OUD would mean early treatment. Positive youth development perspectives could be incorporated in this by, for example, not stigmatizing opioid use and recognizing that young people with OUD are whole people with lots of strengths to help them and their current challenges. This same perspective is essential in tertiary prevention, which focuses on recovery from long-term OUD. With the youth development approach, program success is defined by the promotion of healthy development for all young people involved. Adopting the youth development approach is an effective way to work with young people in any program area at any level of prevention. An early leader in youth development, Gisela Canopa, once said, "Youth development is something that isn't something you add to the plate. It is the plate." Excuse me, I emphasized the wrong word. Let me read that again. Youth development isn't something you add to the plate. It is the plate. All right. So, how might an OUD prevention program shift from a prevention approach to a positive youth development approach? Now, let's take a look at the table featured on the screen. The deficit approach focuses on so-called at-risk youth and attempts to reduce their risk of OUD. It is fixing a problem. In contrast, the youth development approach focuses on developing the whole person. This doesn't mean there isn't content about the dangers of opioid use, but it isn't the whole content of the program. Some other characteristics distinguish the two approaches as well. Whereas the deficit approach sees young people as the recipients of education or services, the youth development approach sees young people as active participants in creating their own lives, and hence young people are included in designing and conducting the programs they are participating in. Similarly, the deficit approach tends to treat people as individuals with individual problems. The youth development approach recognizes that young people have friends and families and communities that include natural support systems that youth themselves can help strengthen. If the youth development approach sounds a lot harder to implement, it is. But it is so worth it. This approach allows notable benefits and progress towards the promotion of healthy development for all. All right, so with all that being said, where does the youth development happen? The answer, as it shows in this image, is everywhere. As the quote goes, youth development is the plate, not something you add to it. The approach of promoting healthy development is needed in all places young people spend time in. This slide depicts that more proximal contexts have greater impact on youth development than distal factors. Here, we see the focus on family as a more proximal factor to consider. Peers and other adults, caring or infuriating, are also included here as they have more direct interaction. Organizations such as schools or religious organizations do not have the same influence as parents or more proximal sources, but schools do have influence more so than community-based programs that the youth may not interact with as much. This implies that we should focus on resources helping to ensure that the kinds of opportunities and supports are more widely available to all young people in all communities. All right, one way we can support healthy youth development is to support empowering and expansive wording when it comes to working with youth. This may be new to some of you, as you already know. In today's time, scholars have adapted new changes to adapt our language as we work with youth. Changing the language is important for changing preconceived notions about the capabilities of youth and youth development, as well as assist in decreasing stigmas. As we can see on the screen, rather than using the words in parentheses, we use the bolded words. For example, we like to use out-of-school opportunities rather than after-school programs. Partnerships rather than program expertise. Engagement rather than ownership. And academic expansion rather than academic focus. These language changes matter because they affect the way you do and think about positive youth development and supporting programs. The benefits of using this alternative wording include an increased likelihood of motivated participants, higher levels of participant satisfaction, greater trust in leadership, a sense of shared purpose, greater collaboration, and improved creativity. Whoa! Programs may even see an increase in their number of participants recruited, and that's always a benefit. Okay, so seeing that there are alternatives to common language used, let's consider together. If we incorporated these language changes, would people name their programs differently or recruit differently? Now, of course, these are rhetorical questions, as I can't receive a direct response from you, but I think it's important to think about as we all pause together. All right, so let's air this out. Incorporating these language changes, such as using out-of-school opportunities compared to after-school programming, can enhance positive youth experiences and opportunities. They can offer young people the chance to form strong relationships with adults and peers and provide challenging learning experiences and a variety of opportunities for young people to test their wings in a safe setting. In knowing this, we may not change the name of our program or recruit differently, but we may change the way we promote and describe our program to potential participants and funders. All in all, it is never a bad idea to err on the side of using empowering and expansive wording during program implementation and recruitment. All right, and that is the end of session 1. So in summary, today we defined and discussed the prevention model. We defined and discussed the deficit approach, and we defined and discussed the youth development approach. The prevention model is aimed at reducing risks or threats to health. The deficit-based approach is aimed at focusing on the perceived weaknesses and problems of youth. Unlike the deficit-based approach, the youth development approaches promote healthy development for all persons, not just problem youth. And in turn, these approaches both increase the positive and reduce the many undesirable outcomes, not just target the problem behaviors. Now, if you have any questions, feel free to reach out. But again, thank you for joining, and we'll see you next session, session 2.